So the people who were awake for Jan's talk can now go to sleep for my talk, and vice versa. We'll see whose heads are up and whose heads are down. I'm going to give an overview of current therapy for neuroblastoma, dealing with both high-risk and non-high-risk disease. I wish I would have known I could have just talked about high risk. It would make my talk shorter. Okay, so I want to just briefly run through risk stratification in neuroblastoma, and you heard a bit about that in Jan's talk, and certainly we'll hear more about that as the days go on. But in order to frame how we group patients, it's worth knowing how we think about assigning risk from the time of diagnosis. So the key prognostic factors, as many of you know, are first simply age. So age has been shown to be a continuous variable by Wendy London and others, meaning that if you're 17 months and 29 days versus 18 months and 1 day, it's not like your risk changes that simply at the mark of 18 months. But for the purpose of clinical trials and group assignment, we have to draw a line in the sand somewhere. So the current practice internationally is to use 18 months or 547 days as the cutoff. The next very important prognostic factor used in group assignment internationally is stage. And the old system that sometimes it's hard for us to stop using, 1, 2, 3, 4, has switched from the INSS way of thinking about neuroblastoma to the INRG, which I think most of us are being diligent about making our mouths say, L1, L2, M, and MS. And the INRG system is based on the presence or absence of image-defined risk factors rather than the courage of the surgeon. And I've shown an example here of a classic image-defined risk factors whereby the tumor is encasing very important blood vessels and your surgeon says, oh, when they look at it, which generally speaking makes that an L2 primary. And here is just the way that the staging system has been designated, localized versus metastatic, with or without image-defined risk factors. I'm not going to go into too much detail about M versus MS, but for those of you whose minds are still back in the INSS system, for the most part, with a few nuances for the aficionados, MS and 4S are almost overlapping, and that's a special phenotype of patients who have metastatic disease in very specific locations, and that group tends to do quite well. The next feature that is used for grouping of patients in terms of risk is histologic features. And throughout the world, we all look at stroma rich, stroma poor, degree of differentiation, and in some areas there's more emphasis on mitosis karyorrhexis index. Those three features, plus the added feature of age, comprise the International Neuroblastoma Pathology Classification System known as INPC. And there's some differences in whether the INPC is used as is or whether components of the INPC are used in different parts of the world. But the point is that putting this together with age and stage, histology is another important feature that we look at. Jan went into much more detail about the biologic features, but I'll just summarize here by saying MYC remains the most powerful prognostic feature that we use currently in risk assignment in neuroblastoma. And here's a picture of MYC amplification. This was originally described by Garrett Brodieu back in the 1980s and is still used very commonly everywhere today. Around the same time that MYC amplification was described as a prognostic factor, Tom Look and his team looked at tumor cell ploidy, otherwise known as DNA index. And this is still used in infants under 12 months of age. It's very old technology, older thinking conceptually, but still very important in a subset of patients. And then, as Jan discussed in the last talk, the use of segmental chromosome aberrations, gains and losses within chromosomes, has also been shown by Gudrun and others to be very important prognostically. So all of these features are currently used when we think about tumor biology and risk classification. So once we've used all these things together and put them into the chart that Jan previously showed, and I wasn't going to regurgitate, We can divide our patients into high risk and non-high risk. In some areas of the world, the patients are divided into high risk, intermediate risk, and low risk. But for the purpose of this talk, I'm grouping the low and intermediate risk together because I think in large part we can think of them with goals that are a little bit different from how we think about the high risk patients. So let's start with non-high risk. The general consensus is that these are younger patients with more favorable biologic features. These are the patients that are going to go on to do well, and the most important thing we can do is not mess it up. So the goal over the past 10 to 20 years has really been therapy reduction, with a concept being how low can you go? So how little therapy can you give? How can you not mess things up and make these children better? So the ways that people have approached this has been a decrease in the number of treatment cycles, so same drugs but fewer of them, a change in the surgical approach, so instead of doing a big aggressive operation that causes a lot of organ damage, a less aggressive approach, leaving some behind, seeing if the patients continue to do well, which is intimately related to this change in the endpoint of therapy. So do you have to bring these children to a complete remission, a very good partial remission, or is a partial remission good enough in certain subsets of patients? And the example I will give you is, this patient, a child under 12 months of age who presented with this very large tumor that's encroaching, extending through neural foraminae into the spinal canal. This patient received 4 cycles of chemotherapy, had a beautiful response, plus what our surgeon hates it when I use this word, but a debulking surgery, and was left with some tumor still remaining in a little bit of a anxiety-provoking place. But this patient has been off therapy now for many years and is doing just fine. And probably 10 or 20 years ago, we would have treated this kid and treated and given him a lot of toxicity and potentially surgical morbidity, when in fact we could stop at a PR and the patient does perfectly well with favorable biologic features. So this is, I think, a substantial difference in thinking now compared to 10 or 20 years ago. And the result of that has been pretty nice looking Kaplan-Meier curves. So these are data from Claire Twist's ANBL 0531, looking at EFS and OS, and it's pretty hard to get better than this, with a reduction in therapy, a change in an endpoint of therapy, and really, to some extent, leaving these patients alone and allowing them to do well, which is hard for us as oncologists sometimes. So the logical extension of all of this reduction in therapy is a reduction to no therapy, which again is difficult for us as interventionalists, kind of pediatric oncologists. Sometimes just sitting and waiting is the right thing to do. And this has been shown by a number of different groups, including the Children's Oncology Group in the ANBL OOP2 study led by Jed Nocturne. So Jed and his colleagues were advocating first do no harm. So rather than intervening surgically in patients, young patients, perinatally diagnosed patients with small adrenal primaries, they allowed these patients to be watched quite closely. And they looked at 84 patients, only 16 of whom went on ultimately to surgical resection, in many cases due to parental anxiety or treating team anxiety more than actual clinical phenomena. But the majority of the patients did not undergo resection of these small tumors. They got watched, and they did extremely well. And you can see that, in this survival curve, the S is the top line. That's overall survival. Impossible to get better than that. And then survival for a neuroblastoma event shown here, also excellent. So this really supported in a subset of sort of the lowest risk perinatal patients with small adrenal tumors that you could wait and watch and reassure and not cause these small babies any harm. The same approach, or very similar approach, was taken in the German experience in the study shown here. And I've shown the consort diagram from the infants on the NB95S and NB97 studies. And as you can see, there was a sizable cohort here that underwent observation. And the majority of those patients, their tumors either underwent regression or remained stable. And a very small number of patients actually progressed to clinically concerning phenotypes, again supporting the idea that a wait and watch strategy can be appropriate in certain situations. The logical extension of this really important data was that maybe we can go beyond the perinatal patients and the very small tumors, and maybe there are other children in whom we could first do no harm. And so a number of different groups are now studying a logical extension of this approach with older patients, a little bit larger tumors, who have favorable biologic features and no clinical symptoms. And that's being done both in the European context and also in a current COG trial. The caveat to this is a subset of patients where waiting and watching can really get you in trouble. And these are young patients with MS disease. So this was a recent patient of mine, came in on a Friday, of course, and it's a very small baby, gigantic belly, full of liver with neuroblastoma. So this is the kind of patient where waiting and watching really can be a problem. So in the COG ANBL 0531 trial led by Claire Twist, there were a number of these babies enrolled, and fairly quickly, Claire and her colleagues learned that these patients need attention and they need it quickly. So there were 49 patients like this on that clinical trial, and 5 of them died due to complications of hepatomegaly, which I think was a little unexpected for reasons that I can talk about in another context, but pretty impressive. 5 patients who were likely to go on to do quite well, who died very early on. And so when the team sorted out these patients and looked closely at them, the deaths were disproportionately high in patients who were under 3 months of age. So small baby, big liver, holding on physiologically by your fingernails, and when we didn't intervene, those patients began to quickly circle the drain. I think this graph supports that conclusion. The colored bars show you the patients who went on to do well and the patients who died, and you can see that there's a disproportionate death rate in the youngest children. So these are the ones where the patient comes in and the alarm bells need to go off fairly quickly. Both the European group and the COG are studying this in an organized fashion, how to intervene and when to intervene. And I'm showing you an example of how the Children's Oncology Group is guiding that decision-making and really trying to assist investigators in understanding when to pull the trigger. This chart gives a grading of different organ function areas to determine the physiologic risk that the patient runs, and gives guidance when there's a scoring system you can see across the top. When the score reaches 2 or above, according to the protocol, you pull the trigger. Whether you're in Seattle or Philadelphia or anywhere else in a COG institution, we're making the decision based on the same prompts so that we can learn really how valid is the scoring system, number one, but how effective is our intervention when we do it at the same point. So more to follow on that as that study continues. The idea being, though, of intervening aggressively. The other challenge with these non-high-risk patients is that there still are some subsets of patients who have been designated as non-high-risk who really don't do that well. And so we still have challenges with these patients. I've given a couple of examples of patients. So children over 18 months of age with INRG-L tumor, so image-defined risk factors, yet localized, MICN non-amplified, but still have an unfavorable biologic feature. And in some groups, those patients are grouped as high risk, but in other groups, they're not. And studying them as a specific group seems very important to sort of sort out, do they need the whole high-risk therapy that I'm about to talk about, or is there some other way to modulate what we do for them? Another example I've shown here in these EFS curves, again from ANBL 0531. These are infants with INRG stage M disease, so under 18 months of age, but with metastatic disease and at least a single unfavorable feature. And although those patients were considered non-high risk, this is not an EFS rate that we're willing to sit tight on. We want to improve that. But how do we do that? I think that's the challenge. one could say just treat them with high-risk therapy, but as I'll talk about, that's not a walk in the park for the patient. And having the treatment fit the patient's risk more precisely is exactly what we want to do. So we don't want a big fish in a relatively small bowl, but we don't want to put this little fish in this gigantic bowl. We want to make this fit just right. And the potential is that we could use biology and genomics to try to tailor this a little bit better. We're still a little bit of a ways from that, but I would put that out as a challenge to members of the audience who want to sort of make a mark. So now let's talk a little bit about high-risk disease. And this is a Kaplan-Meier curve that is unattractive, I think, to everybody in the room. But this is one of the early studies that was done back in the 1980s looking at multi-agent chemotherapy. And you can see how steep the drop is in the, in the EFS curve and how low it goes. Oops, sorry about that. So with that discouraging curves to start with, I want to be a little more optimistic about what we've been able to do in various cooperative groups around the world. I'm showing the Children's Oncology Group as an example. This is from a review paper by Naveen Pinto and his colleagues, but looking at the improvements successively over generations of studies in the event-free survival for this high-risk group. So how have we done that? And what I'd like to do next is just walk you through the various parts of high-risk therapy and outline the questions that we've asked in each part and the successes that we have and the challenges that remain. So let's start at the beginning in our tour of neuroblastoma therapy, looking at high-risk therapy with induction first. So the goal of induction is to take someone with a very significant disease burden, like this patient, with a high Curie score, a substantial primary disease in the liver, and reduce the disease burden in using a variety of modalities to where we get to the end of induction, a nice clean MIBG scan, primary completely resected, and liver lesions improving. So how did we get there? In Europe, their standard therapy has been rapid COJEC, which involves the sequential and temporally dense administration of chemotherapy cycles, as you can see here, very platinum heavy. And this is a diagram from Ruth Laudenstein's paper in the Lancet Oncology from last year. These courses are given quickly with surgery performed at the end of the chemotherapy when possible, or after additional cycles of chemotherapy if needed. At the end of these chemotherapy cycles, stem cells are harvested for the next phase consolidation. So the rapid COJEC has been very successful in the European hands and has improved end induction response rate quite significantly. But the Ciopen group has continued to ask questions, particularly about how to improve end induction response rate and how to identify an induction strategy that will work most advantageously with all the therapy that follows, because certainly we don't stop after induction. So one of the questions that the European group has asked has built on the N5 regimen, which was originally developed by the Sloan Kettering group some years ago, which has a different combination of intense multi-agent chemotherapy. And in the R3 randomization in the high-risk neuroblastoma study, the last high-risk neuroblastoma study in Europe, this was the randomized question. And patients who did not have an optimal response at the end of their planned induction could go on and get additional cycles of therapy plus surgery. And the results of that randomization will be presented later this week. So stay tuned for that. In North America, we've taken a little bit different approach. Still intensive chemotherapy with somewhat different agents and a little bit different order of events. So this is a diagram from a study that was a regimen that was originally piloted in Julie Park's hands in a pilot study in the COG and then studied more intensively in the randomized ANBL 0532 trial, and then was used again to answer a different question in a subsequent pilot study led by Megan Granger. But the, oops, I keep doing that. But the induction therapy, you can see here 2 cycles of topotecan and cyclophosphamide, an early stem cell harvest, followed by additional chemotherapy, relatively early surgery compared to the European approach that you saw on the previous slide, and a last cycle of induction chemotherapy. The response rates at end induction on the 0532 study, and again, very, very similar on the 12P1 study, are about 80% objective response. So that's very encouraging compared to that horrible curve I showed you first, but still drives home the point that although we are getting more successful with our induction therapy, that means still 20% of patients are not having a great response, and a smaller percent, less than 10% of patients are progressing right through our induction therapy. So still a way to, an area that's open for improvement. So how could this be improved? And I think, again, the Europeans are being very rigorous with a randomized approach. And in the next study, thank you, Dominique, for the slide demonstrating the next randomization in the HR-NBL2 study. But this will be looking at the standard arm with rapid Kojak, as you saw before, being evaluated at the same time as a regimen that was previously studied by the German group with the agents that you can see here. A little bit different timing of surgery and stem cell harvest as shown here, and we'll be anxiously awaiting how that induction randomization will turn out. Another important thing to think about when we think about these induction regimens is that they're not given in isolation in our therapy. So we can look at induction and induction response rates all we want, but we have to think about what comes after for our patients. So the way I usually explain this to our new fellows is you can have a great shirt, but if it doesn't go with your pants, it's not going to work. So when I think about high-risk neuroblastoma therapy, I think about it as an entirety, and so your induction regimen could be quite successful in one setting, but if it's not going to lead your patients to a successful consolidation or post-consolidation, that may not be the best overall regimen. So I think all of the cooperative groups around the world are trying to be very cognizant of this fact and ask induction questions, but at the same time ask how those inductions fit with the almost a year of therapy that is going to follow. So I didn't want to skip over surgical local control, even though it's a little bit jumping back in time. I sort of led you to think I was about to talk about consolidation, but I do want to pay attention to the surgical issues because they're important, and undoubtedly there are surgeons in this audience. There have been a number of different studies looking at surgical local control in patients with high-risk disease, and there are always questions about how aggressive should a surgeon be, and does the maximally aggressive therapy on the primary tumor impact outcome? And the answer is approximately as clear as mud. There have been several important papers addressing this issue, but the complications are that they're done with the bigger picture being a little bit different. So this slide sort of gives you the example of that. This was done by Torsten Simon and his colleagues in Germany. And what you can see here, these are different levels of surgical or degrees of surgical resection. So no surgery, 50 to 90% reduction, greater than 90% reduction, and complete response or complete resection. And you can see when it comes to event-free and overall survival, those curves are right on top of each other. And even when they appear to be a bit separate, you can see there's really no statistically significant difference in local PFS with respect to the primary tumor. Now, this is a little complicated because these patients received a fairly substantial radiation dose if they had gross residual disease behind, which may have mitigated some of the effect of an incomplete resection. In addition to that, this study was designed to look at other questions. So some of the patients got transplant, some of them got post-consolidation therapy, and you just have to be very cognizant of those nuances when you look at the question of surgical local control. This is in contrast to data that were published subsequently by investigators from the Children's Oncology Group. And again, they're looking at degree of resection greater than or less than 90%. And the results here could be interpreted differently, but again, one must have to pay attention to the nuances. So these investigators focused most on this local progression. This is very similar to the local PFS curve, just turned the other way. But looking at patients who did or did not have 90% reduction in their tumor size, this would suggest that perhaps there is an advantage to more aggressive surgery. But remember, you got to look at the whole thing. You got to look at the whole therapy. And these patients had a little bit different approach. all of the patients received radiation to their primary tumor bed, regardless of whether or not there was residual disease left behind. So that may have, again, mitigated the results of the surgery for some of those patients. These patients, in contrast to the prior study, did go on to get transplant and immunotherapy. So I think there's a tendency when we read a paper to look at one paper says one and one paper says the other, and I think we have to be a little thoughtful about this and understand that the patient populations were a little bit different. So I think the debate remains about surgical local control and needs to be considered by us when we design our trials. I think ultimately I and many of my colleagues draw from this the surgical issue that probably when we think about this in its entirety, that the best safe resection may make the most sense. So an aggressive resection, but one that preserves organ function so that patients can tolerate the consolidation therapy that I'm about to talk about, as well as the post-consolidation immunotherapy as well. Certainly, there can be more discussion on that point. Okay, so let's go on to consolidation therapy. The early data from Kate Mathey and Frank Berthold's groups are shown here. These are papers that have been published quite some time ago, and both suggest that there's an advantage to megatherapy, as some call it, or augmented myeloablative therapy in terms of event-free survival in patients who made it through induction therapy. So how has this been refined since these original papers were done? In Europe, there has been a long tradition of using busulfan and melphalan, and this was based on a paper from the late 90s by Hartman and colleagues, showing the advantage of using busulfan and melphalan over a collection of other regimens. So BuMel has become the standard of care for consolidation therapy in Europe. On the other side of the Atlantic, the historical preference has been for a regimen that includes carboplatin, etoposide, and melphalan, as shown here. This is the schema from the A3973 study as published by Sue Kreisman and colleagues. So the Cyopen group took a look at this and said, let's do a randomized comparison, let's see which one is better. And importantly, this was following an induction, a rapid Kojak induction, so all patients got the same induction, and then patients were randomized to either busulfan melphalan or carboplatin etoposide and melphalan. The results of those were published by Ruth Laudenstein's group in 2017, and I think many people have seen this. The difference here with busulfan melphalan and carboplatin etoposide and melphalan in terms of event-free survival as shown in this figure. What's interesting to us, and I think when you think about that issue of your pants have to match your shirt, that the curve for the CEM shows a pretty low event-free survival, lower than you may have seen in curve from Sue Kreisman's paper, and I think that just drives home that we have to think about our multimodality therapy in its entirety. But from these results, the conclusion was that busulfan melphalan was the regimen that this group was going to take forward. And at the same time, while that question was addressed, in North America, we were asking a question about how could we improve on SEM as well. And so one of the questions that was asked by Julie Park and her team in the ANBL 0532 trial was to look at single versus tandem transplant. So those are shown here, a single cycle of SEM versus cyclophosphamide and thiotepa versus SEM. And these results have been presented by Julie previously and show that there is an improvement in tandem transplant. I'm going to focus on event-free survival, but clearly an improvement in event-free survival both in all randomized subjects and particularly in those patients with stage 4 disease over 18 months. So the European group has looked at this experience and again is moving on to ask another randomized question, looking at patients with an adequate end induction response, looking at their standard BuMel versus a little bit modification of the tandem approach, and we look forward to having that study open and find the results from that. Before I move on to post-consolidation therapy, I want to finish consolidation and just ask a couple of questions about radiation therapy. The question that has been asked in this field is, could more be better? What's the right dose? What's the right field? And I think those are very difficult issues to address because we're always so busy asking other questions. But the radiation oncologists do ask questions about lymph node coverage, and there are a lot of nuances to questions in the radiation field that I would encourage others to pursue. I'm going to pick up the pace in the interest of time. I'd like to address post-consolidation therapy just briefly. Many of you are familiar with the use of cisretinoic acid at the end of treatment after a transplant. And of course, I think this audience knows well the importance of GD2-directed immunotherapy in the post-consolidation setting. These are data from Alice Yu and colleagues looking at the addition of dinutuximab with cytokines and cis-RA compared to cis-RA alone. This therapy resulted in a 20% improvement in event-free survival, but as you know, it doesn't come without a cost, so the toxicity associated with this regimen is significant, and the main toxicities are listed here. This regimen was studied with cytokines, and the question is, do cytokines really matter in outcome with this regimen? And the risk-benefit balance with IL-2 has to be considered. The European group asked the question in a randomized fashion whether the addition of sub-Q IL-2 improves outcome when given in the context of a different antibody, but still a GD2-directed antibody. And what they found was that there was no difference in event-free survival in that trial. It should be recalled that 44% of the patients assigned to IL-2 stop therapy. And so although the trial result is intriguing, it's a little unclear as to whether, had those patients been able to continue the IL-2, would that have resulted in a difference? And so the next question that has been asked is about a little different way to give the dinutuximab and whether IL-2 in that context would improve outcomes. So this is work that's based on Holga Loda's studies looking at a long-term infusion of dinutuximab in combination with interleukin-2. And what these investigators have found is a particularly dramatic reduction in the incidence of pain. So a question that should be asked is whether the long-term infusion in the context of IL-2 results in an improvement over the long-term if infusion alone. Many of us would certainly like to get rid of IL-2 as a component of therapy, but it remains to be seen whether that will be as effective. So what I've just described for you in sort of a whirlwind tour is this very intensive multimodality therapy that is complex to think about and complex to deliver. Lisa Diller will be talking about late effects of neuroblastoma therapy, but I think you can see there the little patient you saw on the first slide came through all of that quite well, but she faces a host of issues that certainly should give us pause. So one of the questions we want to ask is, can we be a little more nuanced about this? Can we use our knowledge of biology to deliver effective therapy that won't be quite so toxic? And I think there's a lot of excitement about using targeted therapy, addressing ALK and other aberrations that might improve our outcomes. So one of the things that we're looking at in the Children's Oncology Group is the addition of crizotinib to our standard therapy in patients with an ALK aberration. And so you can see here patients are going to be pulled off in the next high-risk study if they're found to have an ALK aberration, and crizotinib will be delivered through treatment. So that's our typical standard, is to add something on. We're always piling on and never taking away. And I think the pressing question for us as investigators is, can we use our knowledge of biology and biomarkers to select the therapies that a patient is really going to benefit from and get rid of the patients that get rid of the therapies that are not going to help our patients. So for example, Steve Dubois is going to talk about the addition of MIBG to high-risk therapy. But the question that I would want to ask is, can we identify biomarkers that would predict the patients who are most likely to respond to MIBG? And could we then get rid of transplant? Could we then get rid of some chemotherapy and have a treatment that's going to be more effective and less toxic for these patients? Another example might be to identify patients who are going to be exquisitely sensitive to immunotherapy of various types, and again, be able to get rid of some of the more toxic components of our standard treatment. That is where I hope we can be 5, 10, 15 years from now. So similar concept to our non-high-risk patients, stop making them so sick and get to where you want to go. How do we develop biomarkers? So far, it feels like a little bit of a black box, but hopefully this week we'll learn a lot more about it. I think it's going to be more complex than in some adult cancers where there's a single test for a single gene that guides your therapy. But hopefully we'll be able to learn more about biomarkers and more about targeted therapy so that we can continue to improve our outcomes. This is just a slide put together by Frank Berthold and his group, again showing the improvement in outcome over time. And what I'd like to see is the curve up here with less toxicity for our patients. So I'd just like to thank some of the people who helped me with everything related to neuroblastoma and some of the people who helped me with the slides for this talk.